3 trials looking at metastatic disease, really looking at the role of antibody-drug conjugates. And then there's been 2 trials really looking at metastatic non-small cell lung cancer with MET amplification. And I put the presentation author and abstract. Some of these have actually come out in publication, which is, I think, a great asset when you can see the presented and you can see the full publication at the same meeting. Starting with NEODORA, I mean, I think the DORA study was sort of a landmark study in the management of EGFR-mutant lung cancer, and that patients with non-small cell lung cancer and surgically resected received osimertinib or placebo, and the 2 endpoints were disease-free survival and overall survival. And the trial met its endpoints, and there have been other EGFR-TKIs that have been investigated at this point as well. And you can see there are very robust improvement in disease-free survival. But if we kind of look at 36 months, we start to see that curve come back down with, it seems to be a higher rate of recurrence. And I think that's important clinically when most people get 3 years of therapy. And as you can see here, there's also an improvement in overall survival there with a difference of about 10% in the 5-year survival, 88 versus 78%. In the time that osimertinib was approved and available for adjuvant therapy, there was also this trial ongoing called NEODORA, which had a different design, and they took patients preoperatively with EGFR-mutant exon 19 or exon 21 local central tests, and they're assigned either osimertinib with chemotherapy, osimertinib alone, or chemotherapy placebo, which in the red represented the control arm. The primary endpoint was major pathological response, which for this study was defined as less than 10% residual viable tumor in the lung primary. Secondary events were event-free survival, pathological complete response, and nodal downstaging. And so this is sort of the patient disposition. Rather than doing the usual consort, I found it a little bit easier to do it in the table form. There were about 120 patients in each of these arms. If we kind of look at this, I think 90 to 95% of patients went to surgical resection. And I think that that's important because I think there was some concern that preoperative EGFR-TKI therapies may either lead to disease progression or pulmonary toxicity that would preclude the curative surgical resection. But we really do not see that as a problem. There's no toxicity signal that we're sort of compromising this. And the second part is that patients could go on to adjuvant osimertinib either provided by the trial or by commercial supply. And this sort of evolved as the trial was ongoing. It was conceived as a preoperative trial, but when ADORA read out, adjuvant osimertinib became widely available, so you had to build that into protocol. So what conceived as a preoperative trial effectively became a perioperative trial halfway through to do changes in standard of care. And I kind of look at the pathological endpoints. The primary endpoint of major pathological response is up there, 26% compared to 2% in the chemotherapy arm, or 25% with osimertinib. And so the trial met its primary endpoint. If we look at the path CR, it was around 4% versus 9% versus 0%. And I think as this trial has been sort of gone through the process, a lot of people have said, well, why didn't they use path CR? And I think the reason is that statistically, the rate is so low that it would require a very large trial to show a difference in path CR because the rates continue to be low. I think with both these endpoints, I'm personally hesitant to translate the experience with immunotherapy to a targeted therapy. Because like in ADORA, we know when the targeted therapy stops, the cancer can potentially come back because it's no longer suppressed. With immunotherapy, what we've seen is the path CRs are really durable without additional therapy. Now looking at the other endpoint was nodal downstaging. Importantly, you had to have a biopsy and confirm N2 disease at the time of study entry, and then you had to have it assessed at the time of surgery. So this is sort of a subset analysis, and you see the number of patients is relatively small. And you can see that that some of them were downstaged. Now this is downstage from N2 to N1 or N0. So it's not the complete nodal clearance that some of our older trials have used, but it is sort of downstaging. And you see the rates are about 50% on the two osimertinib arms and 21% on the chemotherapy arms. In some ways, I think this sort of implicates chemotherapy wasn't really that effective, as a preoperative therapy for these patient population. If you kind of look at that major pathological response rate, and the downstaging rate is very low.